So we're going to go ahead and get started. It's my pleasure to introduce Dr. James Grenert as our first GI Grand Round Speaker of the year. Dr. Grenert is a professor of pathology at the San Francisco General Hospital, and he obtained his MD and PhD degrees at the Mayo Clinic in Rochester. He completed pathology residency and fellowship at UCSF and joined faculty here as well. He is an attending surgical pathologist at the San Francisco General Hospital. His specialty areas include surgical and molecular pathology, and he was medical director of the UCSF Clinical Cancer Genomics Lab for 8 years, during which the UCSF 500 Cancer Panel was developed. His research interest is in the use of molecular testing to improve pathologic diagnoses. Speaking from personal experience, we as fellows love it when we can take a trip to the Path Lab to review slides with Dr. Grenert because it's such great learning. And so today we are lucky to welcome Dr. Grenert to our GI Grand Rounds to share his expertise on GI pathology. Thank you so much, Dr. Grenert.
Thank you so much for giving me the opportunity to talk to all of you. I really value my work with the GI group, and it's been fantastic getting to know so many of you over the years. So the talk today is we're going to go end to end through the GI tract and cover normal histology and some things that you commonly see. There are going to be some new things compared to last year's talk, so that those of you who saw this before will see some new things, but we'll also cover basics so that the new fellows will get up to speed. And then also I wanted to make sure that we cover some more liver this time compared to last year. I have no disclosures. So here's examples, starting on the first end, the esophagus, normal esophageal squamous mucosa. So the basal layer at the bottom here is where the stem cells are of the esophagus, and so they're continually regenerating, and as the surface epithelium, wears away and sloughs off. And so these are the proliferating cells in the esophagus. And they're normally just, a small, thin layer along the bottom here. They don't become prominent unless there's higher turnover. And then you start to see the basal layer start to get thicker and more prominent. And so we see that in kind of generic examples of esophageal injury like reflux disease. One other thing to note here is that there are these little vascular papillae, and normally these don't go any higher than about halfway up or so in the mucosa. When you start to see them start to approach the surface of the mucosa, then you start to again think about the possibility of some sort of reactive process and esophageal injury. So here's an example where we have both of those changes. So this indicates that there's some sort of injury going on. So the basal layer, instead of being sort of a thin layer, is really sort of thickened and kind of creeping up. And then you can see that these vascular papillae are almost reaching the surface here. So it gives you the impression, there's some sort of injury going on in the esophagus. And so when we look at the squamous mucosa, we see interspersed in here are a bunch of cells that, stand out because they look very, very red. Here's another example. Again, the basal layer, here probably goes maybe 2/3 the way up. So a lot of really reactive looking epithelial cells. Again, some red cells in here. When we go zoom in on higher power, we see that the red cells have these bright red granules indicating that they're eosinophils. We see these little pockets here with, multiple eosinophils within a little cleared out space. We call these eosinophil microabscesses. So here, you could do counting and, so like, there's this many eosinophils per high powered field. But for this particular entity, I personally feel like, if there's too many eosinophils, that there's too many eosinophils. And that certainly was what the last example was. So there's kind of a more generic change of reactive squamous epithelial changes. But with eosinophilic esophagitis, there's just numerous eosinophils where there's so many, you look at it, it's like, I'm not going to count these. But one of the catches, though, is that more subtle cases of eosinophilic esophagitis can have a lot of overlap with gastroesophageal reflux, which has the reactive epithelial changes. It has increased eosinophils. And so in cases of EOE where, the number of eosinophils isn't so prominent, it's really hard to differentiate between the two. And so you really want to correlate with your endoscopic and clinical findings. Moving down now from the esophagus toward the stomach. So this is the gastroesophageal junction. So the esophagus is on one side of that. That's the E part of the GE junction. And then on the right side here is the G part, the gastric epithelium. So we go from squamous mucosa to glandular mucosa. This is, one of the two squamo-columnar junctions that we've got in the GI tract. And so here, this should have glandular type epithelium, and we'll see some of that on higher power. No goblet cells in here, just this pinkish mucin vacuole present in this gastric foveolar type epithelium. So here's an example at higher power, again, the GE junction. And so here we can see a lot of cells here that have pinkish mucin present. Then there's a few other cells here that look a little bit more bluish. When we look on higher power, this is what normal gastric foveolar epithelium looks like. So pink, apical mucin vacuoles in here. They're kind of small. But then interspersed in here, we have different mucin vacuoles that are larger and have kind of a bluish mucin. And actually, you can see here that it squashes the nucleus down to the bottom of the cell. So these are goblet cells, and they're not a normal component of gastric epithelium. They're actually a part of, what we see in the intestines. And so this is intestinal metaplasia. And so this then would correlate with, endoscopic findings. If you saw the salmon-colored mucosa, then this would fit with Barrett's esophagus. And so again here, these bluish, large mucin vacuoles, this is intestinal metaplasia. In this case, there's no cytologic dysplasia here. The nuclei are all still small, not very dark staining, very uniform from one to the next. So we don't have any concerns about any bad things going on here. So intestinal metaplasia of the gastroesophageal junction in the United States anyway requires the presence of the colonic-like goblet cells. And if you have the appropriate endoscopic findings, then that would support a diagnosis of Barrett's esophagus. And of course, the real significance of this finding is this can progress to dysplasia and carcinoma. So this is an example of intestinal metaplasia, but instead of our prior case, we see a lot of really dark staining nuclei, and they're really crowded in here. And so, this kind of stands out as looking different than our last case, which had, really pale staining nuclei that didn't really jump out at you, certainly at this magnification. When we look on higher magnification, we can see a lot of crowding. A lot of the nuclei are kind of going up and down, so that we call it pseudostratification. So, the nuclei don't keep their normal basal location. They're creeping up almost, all the way toward the surface in many places here. On higher power, we can see some, pretty bizarre, very enlarged nuclei, quite a bit of variation in the size and shape of some of these nuclei, and very, very dark staining. So this is dysplasia occurring in Barrett's esophagus. And dysplasia here is similar to the kinds of dysplasia we'll see elsewhere in the body. So when we evaluate biopsies that have Barrett's, we always comment on, the status of the presence for the presence of dysplasia. So it could be negative for dysplasia. There can be low-grade dysplasia. There can be high-grade dysplasia. In this case, I would say, was low-grade dysplasia overall. But then there's this category of indefinite for dysplasia, and that's a category that's used when there are features that could represent dysplasia, but there are circumstances, maybe associated inflammation, or maybe just technical aspects of the biopsy where things aren't all that well visualized, where you don't feel that you don't feel certain that you could reliably identify dysplasia. And so that's when indefinite for dysplasia is used. And by the way, anywhere along this talk, feel free to chime in with a question. Just go ahead and speak up. I can't see the chat right now. Moving on now, further distally to the stomach here. This is actually a biopsy of the antrum, the distal aspect of the stomach. And so this one just has a uniform, throughout most of the antrum, it's a uniform mucinous type epithelium without the specialized cells making acid and enzymes. One of the things that's common throughout the stomach is that the glands are pretty much back to back. They're packed in here pretty tightly. There's not a lot of space between them. And when you do see some space, it's mostly clear. And so that's something that we scan for when we look at these at low power, to kind of give us an indication as to whether or not there's likely to be some disease pathology going on. So this example, a similar magnification shows, wow, all of these glands are no longer back to back. There's quite a bit of space between them. And instead of being clear in between the glands, there's a high degree of cellularity in here. There's basically a lot of blue cells, right, in between all of these glands here. So we have an increased, expanded lamina propria with a lot of blue cells kind of pushing apart the glands here. And so we want to go ahead and take a look at that on higher power. When we look at that, we can recognize that there are many, many, many plasma cells in here. There's also some lymphocytes, and kind of scattered around, we see some neutrophils. And here's an example with a lot more neutrophils. So, there's really a lot of inflammatory cells, specifically neutrophils, within the epithelium here. And so this is what we call activity. And so there's some chronicity with the chronic inflammatory cells, the plasma cells, and to a lesser extent lymphocytes. And then there's some activity here. So this would be chronic and active gastritis. When we zoom in on higher power of a lumen here in this biopsy, we'd actually see that there are a lot of little kind of slightly curved, they are almost like sort of like a slightly curved C or a rod here. And so this is what Helicobacter looks like. And so these are many, many Helicobacter organisms here. So in this case, there's just so many of them that they show up on an H&E stain, and you can readily identify it without any additional help. Here's another case of chronic gastritis, and it looks like there's probably some activity. I think there's maybe a few neutrophils there. It's a little hard to tell, but in any case, it's clearly chronic gastritis. And on the right side here, you see those same goblet cells that we had seen in the GE junction here. And so chronic injury from chronic gastritis can end up resulting in intestinal metaplasia and atrophic gastritis. Here's an image of higher power showing again the difference between the gastric foveolar type epithelium and then the presence of these really large bluish mucin vacuoles indicating intestinal metaplasia. So H. pylori gastritis, can be chronic with the lymphocytes and plasma cells, and there can be activity, but not always with the presence of neutrophils. Sometimes you can see the organisms if there's a lot of them, or if you just happen to get lucky where you're looking around, you can see them on H&E stain. But if not, you can use an immunostain to pick those up, and so that can be very helpful in more subtle cases where there's not a lot of organisms and you can't see them readily. So again, the real significance, because H. pylori gastritis, causes chronic injury and has a number of adverse consequences if it goes on for a long time. So beyond intestinal metaplasia and atrophic gastritis, you can then develop dysplasia, adenocarcinoma, and lymphomas. This is another example of a gastric biopsy where the lamina propria is expanded. And so again, just like last time, we see a lot of blue cells in between the glands here instead of the tightly packed back-to-back glands that we should see. And so again, you want to go in on higher power and see what's going on. And so we look in here, okay, definitely increased cellularity between these glands. I can't quite tell what they are. And so you look on higher power, you realize, oh my goodness, these are actually not plasma cells here. They're still pretty small cells, but they're larger than plasma cells. And if you just want sort of a built-in yardstick, there are a few plasma cells in the background here, kind of in the lower left. And so that's what a normal plasma cell would look like. So even though these cells, are still pretty small, they're a lot bigger than a plasma cell. And so this tells us this is actually a different type of cell. And so when we appreciate kind of the individual histology of some of these cells, you can see that there's actually a distinct large mucin vacuole with the nucleus pushed to the periphery. And so this is the classic signet ring cell that we see in discohesive type adenocarcinomas. The classic example is in the stomach, but these can occur anywhere in the GI tract. So this is a poorly cohesive, diffuse type gastric adenocarcinoma. Again, these can occur anywhere in the GI tract, but they're more common in the stomach, and that's where they're really well known. One of the underlying molecular defects in these tumors is they have loss of E-cadherin, which is a cell-to-cell adhesion molecule, which normally causes these epithelial cells to stick together and do things like form glands. And so in this case, that's no longer present, and so the cells don't stick together anymore. One thing to keep in mind is that there are actually individuals who inherit a defective CDH1 mutation. And so those patients are at risk for gastric cancer and also a type of breast cancer called lobular carcinoma. And so if you have a very young patient who has a diffuse type adenocarcinoma, definitely consider doing germline testing to evaluate for that possibility. One of the things that makes this so hard for not just the pathologists, but also the endoscopists and the surgeons who try to resect these is because the cells don't stick together, this may not form a mass lesion. And so it really can make it hard to see endoscopically and also during surgery. And it can be hard to assess the size of the tumor, the depth of invasion of the tumor. There are examples where on a resection, you don't see any evidence of tumor at all on the outer aspect of it. And then you cut into it and look at it under the microscope and you realize that there's actually tumors crawling all around on the serosal surface. So they're very, very sneaky, very problematic tumors to try to identify and treat. There's an old saying in pathology, if you haven't missed a diffuse gastric carcinoma, you will, So it's an unfortunate thing. They're really, really tricky. Moving on to the duodenum, here's normal duodenum. So, I'm sure you realize that there are villi in the duodenum. And so we see these nice long villi. They're about, maybe 5 times longer than the glands in normal duodenum. There's also these mucin-producing Brunner's glands here. So these are nice tall cells. There's not a lot of cellularity within the villi. We can see that here. So these are all epithelial cells. We're now in the intestine, so it's normal to have goblet cells, which you can see here. Then there's also these absorptive type cells that have this kind of eosinophilic reddish, refractile surface. So the little microvilli that help us absorb nutrients in the small intestine are present here. And so there are maybe like a few lymphocytes. Here's one here. They're a little bit darker, and they have kind of a clearing around them. Here's another. So you can see a few lymphocytes in here, but not really many. You kind of have to look around for them. And so this is the normal appearance of the duodenum. Here's an example of an abnormal duodenum. Just from low power, you realize, oh, wow, the villi are really short in here. They're actually, rather than being 5 times longer than the glands, now the glands are, maybe like 2 or 3 times longer than the villi. And so villi are clearly blunted here. When we look at higher power at the villi, we can see that now there's a lot of obscuring of all those epithelial cells here. And we got a lot of little dark round nuclei in here. So these are the lymphocyte nuclei. And so there are innumerable intraepithelial lymphocytes here. And this is the key thing to help us diagnose celiac disease. So this is, caused, of course, by gluten hypersensitivity. And so the really important thing we want to identify is intraepithelial lymphocytes. And of course, the blunted villi are very obvious and certainly a useful feature, but that's only something that we see in more advanced disease or more progressive disease. And so early on in the disease process, the finding might only be the intraepithelial lymphocytes. And so that's one of the things that we really focus on when we try to evaluate these biopsies. One thing to keep in mind is that, if you get a report that says that there are blunted villi, not all blunted villi are celiac disease. And so there's many, many things, as I have listed here, and things that I haven't listed here that can be associated with blunted villi. And so that feature alone doesn't mean celiac disease. And so, you really want to correlate that with your laboratory studies. Moving on now to the colon. This is an example of normal colonic epithelium. The glands in the colon are super, super uniform. You can see here, they're all nicely oriented, perpendicular to the lumen, very regular spacing, very uniform from one gland to the next. So it has a very, very orderly architecture, and that's the alteration of this architecture is something that can be very helpful in identifying disease processes. On the left side here, you can see like, oh, well, where'd the glands go there? So this is just a normal lymphoid aggregate. They're definitely present in a normal process or just in normal colonic mucosa. So this doesn't indicate any kind of abnormality. What would be abnormal is instead of being this kind of rounded, sharply demarcated lymphoid nodule is that if you saw diffuse lymphocytes throughout the mucosa, then that would be an abnormal process. But this is just a native lymphoid aggregate, and there's nothing to be concerned about there. Looking on higher power to some of the histology here, normal colonic epithelial cells, like other epithelial cells in the gut, have basally located nuclei. The nuclei are not dark staining, they're not piled on top of one another. You can pick out very easily individual nuclei. And again, I just want to reiterate, look at how uniform these crypts are here, just one right after another, regular spacing, all oriented the same way. It looks like an Andy Warhol painting. So next up is an example where we have increased cells within the lamina propria. And so instead of being, demarcated like a normal lymphoid aggregate, we're seeing the entire lamina propria filling up with too many chronic inflammatory cells. So something seems to be going wrong here. So let's take a look on higher power. When we look on higher power, one of the things that I notice is that the surface epithelium is kind of indistinct. It almost looks sort of squashed down. It's hard to appreciate the surface epithelium. When we look at that on higher power, it looks a lot like what we saw in celiac disease. You can see all of these little dark round nuclei in here, and here there's so many of them that they're kind of overlapping on top of the surface epithelium that you can hardly see it. You see diminished goblet cells in here, so there's some damage to the epithelium that it's not able to mature normally and produce things like goblet cells. So this sort of disordered and jumbled up and attenuated surface epithelium associated with increased lymphocytic inflammation. When we look around a little bit more, we can see that the basement membrane, which sits underneath the epithelium and helps to anchor that epithelium, is expanded, and it kind of, sort of reaches down and crawls into the lamina propria here superficially. And here you can see an example why sometimes pathologists call this like dripping wax. And you can, it really resembles this like dripping wax, just kind of crawling down in these little tentacles, reaching into the lamina propria, even entrapping cells from the lamina propria. And so this is an abnormal pattern for the basement membrane. If you're wondering, like, what is that pink stuff? You can do a trichrome stain. It stains for collagen, which will stain the basement membrane. And you can highlight here this really expanded basement membrane. It also really nicely highlights the entrapped cells of the lamina propria, which normally should not be a component within the basement membrane. So this is an example of microscopic colitis, and specifically collagenous colitis. And so, the classic clinical correlate is a patient with watery diarrhea, and of course, these individuals have endoscopically normal mucosa, and so the diagnosis is microscopic, hence the name. And so I'd shown you collagenous colitis, but there's also lymphocytic colitis, which is essentially the same disease histologically as collagenous colitis, except it lacks those changes in the basement membrane. And so they have increased lamina propria chronic inflammation, which tends to be more prominent superficially, but in some cases it's all, kind of pan mucosal. Surface epithelial injury and disorder present, which we saw here. And one really key thing here is increased intraepithelial lymphocytes. And so it looks like celiac disease. And in fact, many individuals who have one of these diseases ends up having the other disease as well. And so there seems to be some commonality in people who have too many lymphocytes in the epithelium. And again, the unique feature that makes collagenous colitis what it is in addition to these changes, it also has the thickened basement membrane. Here's an example of colon, which I've zoomed in on, where we can see a different type of epithelial cell within a different type of inflammatory cell within the epithelium. And so in this case, these are neutrophils. This is similar to what we'd seen in the active gastritis in the H. pylori case. So we've got with neutrophils present within the epithelium. So that's called cryptitis when it's present within the epithelium. When the neutrophils kind of fill up the gland here and kind of create this pocket of neutrophils in here, this is a crypt abscess, another type of active colitis. Here's an example on low power where the space between the glands is very expanded here. There's some really funny gland shapes here. There's decreased gland density, and kind of the spacing, is a little bit irregular compared to before. This one's a much more pronounced example of some architectural changes where you have this, sort of backwards K-shaped gland here and a branched gland, and then an area here where there's no glands at all, so some gland dropout. So these are all architectural changes that indicate chronic colitis. So this is an example of inflammatory bowel disease. This specific case was ulcerative colitis. And so when we talk about active colitis, activity means neutrophils. And so cryptitis, the neutrophils within the epithelium, and crypt abscess, where there are those pockets or pools of neutrophils within the gland lumen. Also ulcers, which we didn't show here. So active colitis is not a specific finding, and so it could mean a lot of things besides inflammatory bowel disease. Definitely think about infections and drugs as common things that can cause active colitis. The chronic changes are more specific, but not completely specific. The things that we had looked at before just a moment ago were architectural distortion. Also, you can have increased lymphocytes and plasma cells at the base of the crypts. And then you can have some metaplasias, so some transformation of cells into Paneth cells, or cells that look like the cells of the pyloric glands of the stomach. And so these kind of features indicate a chronic inflammatory process. And so these can more strongly suggest IBD. But some things in particular, chronic diverticulitis can produce a similar picture. Diversion colitis can produce a similar picture. So they're not entirely specific, but they're more specific than the features of active colitis. Moving on to a different entity in the stomach here. Actually, or let me skip over this one here. Here's the, sorry, that was the colon. I misspoke, but this entity I want to point out here. On the right side, you can see that these glands look different than the glands on the left side. On the left side, there's nice mucin vacuoles. The nuclei are essentially not visible at this power. On the right side, the nuclei, which are blue, of course, are really prominent, and even from low power, they really stand out. When we look at this on high power, the nuclei, instead of being all nice and basally located, are now kind of going up and down. They're kind of reaching up about halfway, of the height of these cells. They're really, really packed in there. You can't really pick out one nucleus from another. And so there's a lot of crowding. These are less well differentiated. From low power, we saw that these weren't making nice mucin vacuoles. And so here, the goblet cells, they're present here, but they're really diminished. They're smaller compared to normal. And so these cells are not as well differentiated as normal colonic epithelial cells. And then on this image, you can see the junction between the atypical cells on the right side and the more normal cells on the left side. So basally located, nicely spaced, clearly identifiable nuclei, nice large mucin vacuoles, and then all of a sudden this crowding and overlapping and diminished mucin vacuoles. So this is dysplasia. So this entity is a tubular adenoma, and so this is, a really common premalignant polyp, a huge size range. You folks see these things, just a couple of millimeters in size, but then they can also be several centimeters in size. And so one of the fundamental features of tubular adenoma is the presence of cytologic dysplasia. And so we don't always say, tubular adenoma with low-grade dysplasia. We just call it tubular adenoma because they always have at least low-grade dysplasia. And so when we point out dysplasia, it's usually because there's the presence of high-grade dysplasia, because that's not a standard feature of tubular adenoma. Moving on a little bit further, we're at the anal verge here, and so we see a junction here between glandular epithelium, and then on the right side, squamous epithelium. But the squamous epithelium looks different than what we'd seen in the esophagus. All of these cells have kind of a basaloid look. They're a lot more blue. They don't have more cytoplasm. They're not making very good keratin here. And so even though it looks like squamous epithelium, it looks like that really, really reactive squamous epithelium. that we'd seen in the esophagus before. When we look at another area, there's even kind of
Bueno,
an
sí. Pagi.
Hey, sorry, Dr. Grant. Sarah, I think you're unmuted. There we go.
Uh, yeah, so in this area here, we can kind of see an exophytic area that might endoscopically even look, like a polyp here. And again, we can recognize it as squamous epithelium, but there's really not the maturation that we would normally see. And, there's really very little keratin production here. And so this doesn't resemble the squamous epithelium like, again, we'd seen in the esophagus earlier. And when we look at this on higher power, there's some other abnormal features like mitotic figures, all the way like going toward the surface here. And so normally the proliferative area is just in the basal layer at the very bottom. And so seeing, mitotic figures all the way up at the surface here, this is a very dysplastic feature. And so this is an example of anal dysplasia. And one of the ways that you can identify this with special stains is doing a stain for P16, which is kind of a surrogate for HPV infection. And so here there's very strong diffuse staining for P16. And so that supports that this is an HPV-driven dysplasia. There's also an alternative stain you can use. It's an in situ hybridization for high-risk HPV that we can use for these lesions. So anal squamous dysplasia can colonize the rectal epithelium, and it can totally resemble, like a rectal polyp. The underlying etiology of this is high-risk HPV, and so we can do special stains to identify that. Fortunately, even though these things can mimic colonic polyps, under the microscope, they're pretty distinctive, and so fortunately, they can be differentiated because they obviously have very different follow-up. Moving on to the liver. This is some normal liver from low power. I stole this image from Pathology Outlines. It was taken by one of my former colleagues, Kim Evison, who's now at the University of Utah. I love this picture because it so nicely shows the flow along the sinusoids from the portal tract kind of along here, it's into the central vein right here. And so that's, kind of the normal lobular architecture. And you can see that the central vein here is surrounded by multiple portal tracts, all feeding blood into the central vein. On higher power, this is the portal tract. These are the components of the portal tract. So the large vessel is the portal vein. That's where most of the blood coming into the liver is carried. And then the smaller blood vessel here with the thicker walls, so that's a little bit of muscle. So this is the hepatic artery. And then here, the bile duct here made of epithelial cells rather than vascular cells. And so this is carrying bile. The hepatocytes here, you can see, have eosinophilic, kind of granular looking cytoplasm, so they have a reddish pinkish color here, centrally located nuclei. Here's one fat vacuole, but for the most part in this normal liver, we don't really see any fat vacuoles. This is the trichrome stain that we use to identify fibrosis and scarring in the liver. And so it stains collagen, kind of a bluish greenish color. And there's just enough connective tissue to hold together these portal tract structures. It's not expanded, you don't see any branches of the collagen here. And so normal liver does have collagen, but just enough to hold the portal tract together. Here's an abnormal liver, and so we can see some areas where the hepatocytes look similar to what we'd seen before, but then there are other hepatocytes that look a lot larger and a lot more pale staining compared to what we'd seen. And so let's take a look at these on higher power. So when we look at these are much larger. You can kind of compare some of these background normal looking hepatocytes, and these are maybe 4 or 5 or 6 times as large with really, really cleared out cytoplasm here. And so these really enlarged cells with very cleared out cytoplasm, these are ballooned hepatocytes. Here's an area where we have some neutrophilic inflammation, and again, the ballooned hepatocytes. When we do a trichrome stain in this individual, around the central vein, we can see this very delicate, people call this chicken wire fibrosis running right along the sinusoids and entrapping, individual hepatocytes or small clusters of hepatocytes. And so this very delicate, kind of tentacles of fibrosis typically around the central vein, but not exclusively. This is a classic pattern that we see with steatohepatitis. And so, some key features are the presence of fat, ballooned hepatocytes, inflammation, typically in the lobules, and sometimes you have neutrophils, but not always. A lot of times the inflammation is really more macrophage type inflammation as injured cells die and get cleared out by the macrophages. And so when you have more advanced disease resulting in fibrosis, you end up seeing the sinusoidal fibrosis. And so a lot of times it can be hard to differentiate steatohepatitis related to alcohol or steatohepatitis due to metabolic dysfunction. But there are some features that can be helpful. This is another example where, even from low power, now that you know what a balloon hepatocyte looks like, you can kind of say like, wow, those look like balloon hepatocytes again. Over here are some very regenerative hepatocytes. They have kind of higher NC ratio, less cytoplasm than normal. So this is an individual who had some very severe acute injury, and so the surviving hepatocytes here are really, really regenerative. Let's take a look at on higher power what these look like. So these cells look like balloon hepatocytes from before, but one thing that's really different is they have abundant, very brightly eosinophilic kind of chunky material in here. So here's like, just really, really bright red, really, really coarse material within the cytoplasm. So this is Mallory hyaline. And you can see many, many of these cells are surrounded by, rings of neutrophils. So in that other case, I showed an area where I had to look around quite a bit to find those neutrophils. In this particular example, the neutrophils are just everywhere. They're all over, surrounding these very sick-looking hepatocytes with Mallory hyaline. And so this is an individual who had a binge about a month before this biopsy was taken. And so there's still persistence of the Mallory hyaline here and the ballooned hepatocytes, but we're starting to see some of those regenerative changes. And so this is alcohol-associated liver disease. Again, this is, an acute pattern here with a lot of parenchymal loss and regenerative changes. So some things that can help really make you think more about alcohol is the presence of many ballooned hepatocytes, like, just wall-to-wall with abundant Mallory hyaline. And then when you see a lot of Mallory hyaline and a lot of neutrophils, that is what makes you think more about alcohol-associated liver disease. Now, the fibrosis pattern, though, is not distinct. And so it shows similar sinusoidal fibrosis as you would see in metabolic-associated disease. This is a low power image of liver where we can see some patches of blue. And so that kind of jumps out as something that seems different from before. We don't have any evidence of any kind of nodularity. So from low power, this isn't looking like someone who has advanced fibrosis or cirrhosis. We also don't see much fat. We don't see the pale balloon hepatocytes. We see a few fat vacuoles, but they're pretty few and far between. So it doesn't look like any kind of, fatty liver disease. So here on higher power, we can see that in the portal tract, and I know this is a portal tract because I can see a little bile duct here, and this might be a small portion of the portal vein kind of being cut off here on the edge. So it looks like there's some portal-based inflammation here. We can take a look at the cell type in a moment. Here on higher power, we see like, oh my goodness, there are tons of plasma cells in here. So from your medical school or college histology inflammation, learning about it, that plasma cells have the eccentric nucleus here. So these are all plasma cells here. And we even see some plasma cells spilling out from, going from beyond the portal tract and actually spilling out into the lobule here. And so many plasma cells and plasma cells within the lobule makes us think about autoimmune hepatitis. And again, here we can recognize this as portal because here now we see a nice portal vein present here in association with the bile duct. Here's another area, again, showing many plasma cells in here, and then really extensive infiltration of the lobule with lymphocytes and plasma cells. It's resulting in hepatocellular injury. A lot of these hepatocytes are kind of swollen. They're not quite as big and clear as balloon hepatocytes, but there is some peripheral clearing in the hepatocytes. So the swelling that we see here is something that we see in really severe hepatocellular injury, but they're not quite balloon hepatocytes. And then you can see here the cell's actually just dying right now. So it's the nucleus is getting, shrunken up and pycnotic, and the cytoplasm is kind of collapsing down. So this is basically a dead cell here. Here's a structure here that you've probably heard about. This is a rosette. It's called a rosette because it's this kind of rounded structure with sort of a little bile canaliculus in the middle here. Here's another one here. So these kind of little ring structures. These are classically associated with this particular entity, autoimmune hepatitis, but it actually is just a generic feature of regenerative liver. And so if you have liver regeneration from any cause, for example, on that case of severe alcoholic hepatitis, you can definitely see regenerative rosettes. And so these don't necessarily support or aren't necessarily specific for autoimmune hepatitis. They just indicate severe liver disease, which is often seen in autoimmune hepatitis, hence the association. So classic cases of autoimmune hepatitis really show quite a bit of inflammatory injury, unless the patient is being treated with steroids for some other reason. We like to see prominent plasma cells to help us feel more confident that this could represent autoimmune hepatitis, but they're not consistent in every case, and you don't need to see plasma cells in order to diagnose or at least to support the diagnosis of autoimmune hepatitis. Rosettes, again, are just a generic feature of regenerative processes, and so it's not a specific feature of autoimmune hepatitis. But certainly if we see it, that is supportive of liver injury, and so if we saw things like, interface hepatitis, then, that could be supportive if you have the right labs in association with that. So the catch with autoimmune hepatitis is all of these features are not specific, and so we can't definitively identify it, but, if you tell us that, oh yeah, the patient has an ANA of 1 to 320 and IgG is through the roof, when you put that all together, then that could certainly support autoimmune hepatitis. But you do need to rule out some of the other causes. Viral hepatitis certainly can have complete overlap with AIH. Wilson's can, drug reaction. So you really need to correlate with the clinical findings in the labs. This is an example of a liver where on low power you kind of appreciate some zonality to this, that there's this sort of interspersed areas of looks like some hemorrhage and looks like increased inflammatory cells with areas of preserved hepatocytes. And so you'd want to go ahead and take a look on higher power here. So here, when we look on higher power, we can see the zonality. So here's a portal tract over here. Here's another portal tract over here. Here you can more readily identify the portal tract structures of the portal vein, hepatic artery, and bile duct. And you can see that the hepatocytes around the portal tract here are preserved, like they're present. Some of them are a little bit swollen, so there's probably some injury here. Then as we go here away from the portal tracts, so this is where the central vein is, all of a sudden you're like, where are the hepatocytes here? There's kind of some dropout of hepatocytes. We no longer see that eosinophilic cytoplasm. And so when we look at it in a higher power, here's our central vein, and there's hemorrhage around the central vein. There's an absence of hepatocytes around the central vein, and there's a lot of inflammatory cells in here. And these cells have abundant cytoplasm, and they're containing, kind of some bile pigment and some other pigment in here. So these are macrophages that have come in and cleaned up. And so there's this centrozonal necrosis present here with some macrophages that have cleaned up around here. In this particular case came from a patient who had a recent injury and was taking more Tylenol for that injury than she typically did for some arthritis pain. And so this is an example of acetaminophen toxicity. And so acetaminophen has intrinsic toxicity, meaning that it's not, an immune response to a particular entity. It's just directly toxic to the hepatocytes. And so it has a unique, not unique in that it's specific, but it's just characteristic of acetaminophen, that it has this centrozonal necrosis and then the inflammatory cells that come in and clean up the dead hepatocytes. And so this classic zonality is believed to be due to the formation of toxic metabolites as the drug is transported from the portal system to the central vein and is processed by the liver, and then also possibly to increase susceptibility of the centrozonal hepatocytes to injury from these metabolites. And I will stop here with an end stage, at least as we used to think, cirrhotic liver here. Of course, we know now that cirrhosis can be, at least fibrosis, can be reversible. And so it's not truly the end, but an advanced stage fibrosis liver here. Thank you so much for your attention, and I'm happy to take any questions.